So good morning, everyone. I am Dr. Shilpa Jain from Pune Knowledge Cluster. And on behalf of Pune Knowledge Cluster, I welcome you all for the next lecture in the series Understanding Epidemiology. Today's speaker is Dr. Mukund Uplekar, and title of his talk is Epidemiology to Policy, a Case of Tuberculosis Control. To introduce Dr. Uplekar, he has his training and education from Harvard School of Public Health, Boston. Previously, he was also associated with Institute of Neurology, London, Osaka University, Osaka, Government Medical College, Solapur, where he completed his MBBS and MD. His experiences include, he has been a senior scientist at WHO Geneva, a senior research fellow at Mukund Institute of Health, University of Leeds, UK, research consultant and consultant physician in Mumbai. He also has around 100 publications, including 2 books, several book chapters, papers in peer-reviewed journals on subjects covering tuberculosis control, health systems, private sector in healthcare, health and development, etc. Presently, he is an honorary professor at School of Health Sciences, Savitribai Phule, Pune University. With this introduction, I would like to invite Dr. Uplekar to deliver his talk. Over to you, Dr. Uplekar.
Okay, thank you, Shilpa, and good morning, everyone. And just to clarify all my affiliations that Shilpa just mentioned, I mean, I was at WHO, so I'm now retired, and before that I was in Leeds in UK, and then I spent a year at Harvard as a Takemi fellow. So, well, I'm just told that you're all epidemiologists in the making, and some of you, I'm sure, are already experts, and you have learned a considerable amount so far in epidemiology, and I am expected to offer some insights into the real-life application of epidemiology in developing policies and strategies. Now, I propose to do so by taking the example of tuberculosis, not just because I'm comfortable talking about it. I was a senior scientist at the global TB program in Geneva, the World Health Organization. And I had the privilege of leading the group which both developed and drafted WHO's Stop TB Strategy in 2005 and WHO's Ntb Strategy in 2014-2015. So tuberculosis is dear to my heart, but even otherwise, as those interested in public health, I'm sure you'll be fascinated by this very intractable problem that has been afflicting mankind for a long time. So, so this is to give you just wait a minute. Can you see my screen?
Yes, sir. We can see it.
Yeah, I'm trying to do the page down, but I can't do it.
Sir, you press escape, get out of the full screen and then try. Maybe.
Right. Can you see my screen now?
Yes.
Yes.
Is it full screen?
No.
Yeah, that's good. Thank you. I'm sorry for the. So this is how I have tried to, divide my talk very simply. I mean, I know that the audience that I'm speaking to is pretty diverse, and I would like the least qualified person to understand what I'm saying. So those who are, who are already experts, trained, qualified, will bear out with me if it's going to be too basic a talk for you all. So I think it's good to first talk about some TB and give you some basic information. We will then talk about TB epidemiology, and you can try and apply whatever you have learned so far in trying to identify what kind of, what I'm talking about, whether I'm talking about descriptive epidemiology or analytical dimensions. And I will then jump to the links between TB epidemiology and TB policy. I'm sure you understand that while epidemiology is an important, one of the most important components, determinants of any policy, a health policy, it is not the only determinant, because any policy must take into consideration diverse disciplines, and epidemiology happens to be one of them. So I think it may be a good idea to give you a narrative of how the policies and strategies of tuberculosis control globally, or maybe with a little focus on India, have evolved over the last 40, 50, 60 years. The different components of the strategies, and then leave it to identify, for you to identify yourselves, which of these components, apply the epidemiological information that is so essential for developing any policy. Now, a word about these terms, policies and strategies. Now, these terms are used differently by different people. Policies and strategies are not used just in health, but also in management, almost all kinds of subjects, and people used, with different connotations. And many times interchangeably. For example, if you write to WHO and ask them to send you, the global TB policy, what you will get is a document called Ntb Strategy. So there's something similar for HIV and all that. So, but let's not go into these definitions. Let's keep it aside for the time being as a matter of semantics. So some basics about TB. You probably know that TB is one of the oldest diseases known to mankind. You will find its mention in Ayurveda, which is a part of Atharvaveda, which is nearly 5,000 years old. It's caused by an organism, a germ, a bacillus called Mycobacterium tuberculosis. Its commonest and the infectious form is lung TB. It typically affects lungs, but it can also affect other organs of the body, brain, or it's covering the meninges, bones, eyes, intestines, reproductive tract, even skin. Tuberculosis of the glands of the neck, TB lymphadenitis, is also common. And the common symptoms of the infectious form of TB, lung TB, are cough, fever, loss of appetite, and occasionally blood in sputum. And lung TB is infectious. It spreads through droplets in the air when a person of TB, active TB, coughs or talks. Now we are in the midst of a COVID pandemic, and you will find it fascinating, if you just change a few words and here and there, and how beautifully this description, fits COVID-19 also. You just call it a newest disease probably known to mankind. It's also a communicable disease caused by, the virus responsible for COVID-19, COVID SARS-2. Typically affects lungs, that too also. Can affect other organs also, increasingly. There are cases of stroke and heart attacks and all that. The post-COVID syndrome manifests by cough, fever, certainly true, and spreads through air from persons with active disease. So, typically how this is a body's response to and attacked by a germ, whether it's a virus, whether it's a bacterium. What is key is it primarily affects the respiratory system, but also other organs. So that was a little aside. Some more facts about TB. How do you diagnose TB? It's done by a microscopic examination of the sputum. We call it sputum smear microscopy, and microscopy has been used and is still being used in making diagnosis of TB. It's been in use for over 100 years since Robert Koch discovered Mycobacterium tuberculosis using a microscope in 1882. And it was only as late as 10 years ago in 2010, a new test was developed to diagnose TB more accurately in a more sensitive way. And that's also is a PCR test, RT-PCR for COVID. So the PCR test, the brand name is the Gene Expert, which is used for diagnosing TB. TB is preventable in two ways. There is a vaccine called BCG, but which is only partially effective. It protects children from severe form of the disease, but it does not protect adults from getting TB. The progression of infection to disease in TB can also be prevented by giving what we call preventive treatment, a couple of drugs for 3 to 6 months. So it's called preventive treatment. TB is, of course, treatable and curable, and the commonest form can be completely cured if you use, about four drugs for a period of 6 months. But the long treatment and irrational use of drugs has already led to development of what we call drug-resistant tuberculosis or multi-drug resistant tuberculosis, which is difficult to treat and cure. And that's why deaths or the mortality is high when you don't treat a patient of TB. We know that if there is an infectious TB patient if he's sputum smear positive for TB bacilli, and if you leave this person untreated, almost all of them die within 2 years without treatment. And just to give you the numbers about the MDR TB cases, drug-resistant TB, while the ordinary TB, about 90% patients get completely cured with 6 months treatment, the cure rates in MDR TB are anywhere between 50 to 60%. Now, because the old drugs, as we keep using them, become ineffective, more and more new drugs and vaccines are currently under development. So this is about, the basics. I believe this should be okay for this much information should be okay for you to understand the basics of this disease. Now, some information about the epidemiology of TB. I'm told that you now understand the usual epidemiological terms, the epidemiology parlance, as you can call it. So you will understand when I say that it should surprise you that about a quarter of global population is infected with TB. 2 billion people are infected with TB. Now, I would like to remind you that it means that so many people are harboring TB germs in their lungs, but without causing any trouble. So they are in their dormant state and they're not scared, but there's always a potential that whenever the defenses of the host go down, they can come up with the bacilli can start multiplying and they can develop the disease. So 2 billion people are infected with TB. TB is a top cause of death from a single infectious agent. It used to be HIV before, but TB has now surpassed HIV. And TB is also one of the top 10 causes, due to any diseases globally. And to just put it in numbers, in 2019, 10 million people developed TB and 1.5 million died of it. I mean, look at these numbers. I mean, somehow we have become so kind of insensitive to it that these numbers have probably lost their meaning. Because, I mean, or say about 500,000 cases develop drug-resistant TB, and many of them die or are so difficult to treat. But the important thing is 90% of these cases are in 30 countries which have a high burden of TB. Nearly half the cases are in the region in which we live, Southeast Asia, and every fourth TB case in the world, lives in India. So that's the distribution. So if you just turn these numbers into, so 10 million people, out of which 26% are in India, which means 2.6 million people, and 1.5 million die of it. In India, I think about 400,000 people die of TB every year, which if you divide it by 365, it comes to over 1,000 cases dying every day, which amounts to almost every minute a person dies of TB. Now imagine it's like 4 jumbo jets crashing every day in the Arabian Ocean on the Bay of Bengal. What would be your reaction? And is that your reaction when you say TB? And it's a major problem. So the oldest disease known to the mankind remains the top killer, top infectious killer in the world today. I mean, isn't that a scandal? And why is it the oldest? And so as I said, this is a disease which is preventable, which is treatable, which is curable, and for which there is, although it's not completely effective for all, but there is a vaccine, though partially effective. So this is the some of the descriptive epidemiology. Some more information on the epidemiological facts. There is a great variation in TB incidence. The TB burden across countries varies from 5 per 100,000 population to 500 per 100,000 populations. So because these East Asian countries are populous, the burden in terms of the prevalence, the burden of the disease is high in Asia. But if you take the rates per population, rates per 100,000, they are more in the African settings. In India, I think the incidence is about 195 per 100,000 population per year. Now, most people who develop disease are adults. Now, this is very important because when I say adults, they are people who are productive economically between the age of 15 to 35. Now, there are more cases among men, about 56% than women. So economically productive adult people, more men are suffering from this. So you can imagine the kind of loss to the economy that TB may be causing. It's the leading cause of death among people with HIV also. More than 200,000 in 2019. And while it is the TB bacillus which causes all the damage, in fact, what is driving the TB epidemic are these the 5 that the causes that I have mentioned: the poverty, So when I say a 90% burden is in 30 countries, is because these are the drivers which are actively acting in these settings: poverty, undernutrition, HIV infection, diabetes, and smoking. These are the major drivers of the TB epidemic. And it's obvious if you look at the the HIV infection, for instance, what it does is weakens a person's defense system. And whenever the defense system weakens, well, both you are vulnerable to get infection from outside, but those, and as you know, about 2 billion people are already infected, the germs which are sitting in their lungs in a dormant stage, they can also start multiplying. So you can develop TB both ways, exogenous or in an endogenous way. So that's about the TB epidemiology. Some more information. Now this is just a pictorial, representation of what I just said. The figure on the left side shows the relation between TB and the GDP, which is the indication of poverty. So if you look at the x-axis, as the GDP goes up, if you see that the incidence is going down. So richer the country, lower is the incidence. Or higher the GDP, lower is the incidence TB. On the other hand, if you look in this, on the figure on the right side, as the prevalence of undernutrition, the starving people goes up, the incidence of TB also goes up. So another interesting picture here, because we are right in the midst of TB pandemic, I just wanted to show you how COVID has impacted TB. So you see that this is the weeks of the year 2020. This figure is from the WHO's global TB report, and how the number of cases, TB cases, have dropped significantly with the lockdown. Now, what does that mean? That, so from generally in the first week, in the first few weeks, about 50,000 cases have been detected. That is fallen down to about 20,000. So 30, 40, 50,000 cases, less cases are being detected. This is India, mind you. Now, what does that mean? Does it mean that COVID is protecting TB? Does it mean that, less people are getting TB during the COVID times? Well, obviously not. And it's clearly because it's the attention of the health system is all, given to managing the pandemic. And these people, they may be going to the doctors or may not have the opportunities to go to the doctor. But so many thousands of cases are, currently suffering from active TB, not being diagnosed, or were not diagnosed, and that number is still, lingering. As you say, less and less cases are being detected thanks to COVID. And what is it a reflection of? It basically is a reflection of a health system which is incapable of addressing two crises together. Well, TB, I won't call it a crisis because it's been there for centuries. But it's not just TB. What I'm saying is that's true for most of other illnesses. What happened to, for example, management of diabetes, management of heart attacks, management of anything that comes to your mind when the COVID in the second wave, particularly at its peak? I mean, these people had to suffer, many of them in silence. So this basically drives home the importance of the need to have, because this impact of COVID on TB will definitely have an impact on the way TB epidemic progresses and the way a setback the TB efforts have got, the global efforts, because there are certain targets that the world is supposed to meet, and that is definitely going to be affected thanks to COVID. Now, let's go now to highlight, the importance of the links between the epidemiology and policy development. And as I said, it will be interesting to understand the evolution of TB control policy and strategies over the last 60, 70 years. And I would divide, this TB strategies into 5 phases. TB control before the discovery of TB drugs, that is before 1950s and 60s, where, as I mentioned to you, in 1882, a way to diagnose TB was discovered, microscopy by Robert Koch. But until 1945, we didn't have any drugs to treat TB. So that's one phase. The second phase would be TB control after availability of drugs and diagnostic. And the drugs which were increasingly powerful from 1960 to say 1990s. Then the third phase of the TB policy would be what we may know, those who are conversant with those who are publicly must have heard of what we call the Dept strategy from 1995 to 2005. Then 2005, afterwards is the Stop TB strategy. I think my next figure shows these 3, the Dept strategy, and I have not covered the years before the Dept strategy. So we have a phase of TB before the Dept strategy. Then there were 2 phases before discovery of drugs, after discovery of drugs, then the Dept strategy, the Stop TB strategy, and Ntb strategy. So keep in your mind that, how the knowledge of epidemiology has helped improve the strategy and policies to tackle tuberculosis. I mean, that's what I would like to highlight. So TB control before 1960s, as I said, there were no effective drugs. So all that patients could do, or patients were advised to do, was take enough rest, take good food, good air, exercise, and so on, to essentially improve body's defenses. And that's when, as you know, the sanatoria were built on hill stations and in other places because there was nothing else to do. But as you also know, very few people could afford to go and live in sanatorias. So the second phase comes with the development of the first drug for TB, the streptomycin, was discovered in 1945. And soon this was followed by PAS, para-aminosalicylic acid, and diacetazone, because it was, when streptomycin was developed, there was a euphoria that, we have conquered the problem of tuberculosis because there was a miraculous recovery of the first few patients who were given streptomycin, but within no time, I think within 3 months' time, all these patients started coughing again, and it was soon found that TB cannot be treated with single drug alone, and there have to be at least 2 and even more drugs to treat TB. So there was now a need to structure a program under which services could be organized, because there we had a tool to make a diagnosis, which was microscopy. There were drugs to treat, and at the same time, BCG was also invented. So we had a vaccine, we had drugs, and we had diagnostics. So the need to organize and develop a program was then felt. But in the absence of any hard data, the prevailing perception then was that TB was largely an urban problem, because cities are crowded with their pockets of overcrowding like slums, the air is polluted, people have to work in difficult conditions, and generally the environment is conducive to spread of tuberculosis. On the other hand, In rural areas, the air is good, there is relatively ready access to food, and there is no overcrowding, and generally the surroundings are healthy. So the TB services which were organized during this period are basically hospitals which were located largely in urban areas. So in most of the district places, you will find that there's a big district TB hospital, and the patients from rural areas were supposed to go to these hospitals, were referred to these hospitals, but oftentimes admission to these hospitals was considered a death sentence. But the real situation on the ground became clear only when India, I'm talking about India now, not the entire world, the first national prevalence survey of tuberculosis in India was carried out in 1954-55. And among many other findings, the survey showed that TB is not just an urban problem, but the prevalence of TB is no different in urban and rural areas. It is as prevalent in villages as it is in cities. So just one well-conducted epidemiological study helped rectify the policy and the course of TB control almost overnight. Because your idea of just treating patients in hospitals located in district places was no longer going to work. So, this highlights the importance of epidemiology and not just going by the hunches or what is apparently perceived. One of the problems is that nationwide prevalence surveys it's very cumbersome. It's a very cumbersome undertaking. It requires resources. It requires expertise. And that's one of the reasons why they are not conducted very often. But of late, in the last 5, 6, 7 years, I know because more funding is available for tuberculosis, many countries have done prevalence surveys. In fact, India's second national TB prevalence survey was about to start. All design, everything was ready to go, I think, just before the COVID pandemic hit. And I don't know what's the current situation. But I think that was going to cost something like $40–50 million, so you can imagine. So with this knowledge of the epidemiology, this was critical to design a national tuberculosis program in 1960s. And with this, the diagnostic with the microscopy, the more powerful drugs of 80s and 90s, and the BCG as a vaccine. But because of its chronic nature, somehow the attention to TB control dropped, as it almost went into an autopilot mode. Because detecting a patient, diagnosing a patient properly, making sure that drug supplies for the entire duration, and the drug supply with the older drugs used to be 18 months, and with the newer powerful drugs after late 80s, it was reduced to 6 months. But still making sure that the patient remains on treatment of 6 months. This is both effort intensive and resource intensive. And attention to TB programs became very weak. And there were no, as I said, epidemiological surveys, although there were some statewide, some states went ahead and did epidemiological surveys, only to find that while we were diagnosing and treating, tens of thousands of cases, there was virtually no difference in the incidence rates due to tuberculosis in the country. And that was a global finding also, that, the line showing the trend, the global trend, again from the available data, because not many countries had that data on prevalence available. So it was a kind of almost a straight line. And it was only when there was a rapid surge of TB in the rich countries in the late 80s, I think from 1988 to 89, the number of TB cases in New York City doubled, I think from some 400 to 800. And so that, when the TB started knocking on the doors of rich countries, attention again got back to TB. And that's when in 1995, the DOT strategy was launched. And so that from then on, I think TB has fortunately has remained in the limelight, and there has been sufficient attention, resource and efforts are going on in controlling tuberculosis. Now you can see, I don't know whether you can read the different components of the different strategies, but if you just look at it, you can think and apply and start questioning yourself. Do we need epidemiology? For example, let's take the DOT strategy. The first component of the DOT strategy, it says government commitment. Now, how can you get government commitment? I think not only that the government need to be committed to put in resources, but only if we can shake the conscience of the politicians, only when you have epidemiological precise information, such information that in India today, 1 person dies of TB every minute. This kind of information. Or when in WHO tries to make a case, because it's not just the epidemiology, another important discipline which you will find is critical is economics. So some of the economic studies found that $1 invested in TB today will fetch you $43 in due course of time. Or one of the most cost-effective investments, if you want to make, because the resources are always limited, and every disease or every health condition, the votaries, those who want to, those who are passionate about different diseases or different health problems, and then the diabetes, HIV, or whatever, stroke and heart disease, non-communicable disease, everybody wants to make a case. So, but then there was an article in Economist published at the time of development of the Sustainable Development Goals, which were launched in 2015 as a follow-up of the MDGs. And this article again showed that which investments or which are the best investments for return. And TB was among the top 10, that if you invest, you will get the best returns. So, again, so this kind of epidemiological and economic information in its application can help develop and get attention for development and implementation of the strategies. The second component of the DOT strategy is case detection through passive case finding. That was what the DOT strategy said. Again, based on the research, that if you just start, send an army of health workers into communities just to find TB cases, you will end up finding cases. And if you ask them, you will find that many of them have already gone to health services and sought help for the problem, but have been for some reason sent back. So many people on their own come knocking on the door of the health services, but it's the health services which fails to diagnose these cases. That's why in the DOT strategy, we said we don't have to really go on because that's more resource intensive also. But again, if you want to do case detection, how many cases to detect? Because unless you tell people, or if you just say, go and detect cases, that doesn't help. Because you have to give some kind of numbers that this is such a big number. If you just detect 1 or 2 cases or whatever number of cases, that's enough. So again, to make it precise, roughly how many cases to detect in what period, you need precise information. Okay, just give me one. Okay, and then so similarly, establishing a system of regular supply. How do you know how much drugs to buy? And so for that, you need to know how many cases. And for that, you need epidemiological information. Then look at the stop TB strategy. So the progress, or I would say the attention to epidemiological information, giving precise targets. The goal of the Dept strategy was to detect 70% of incident cases and cure 85% of these cases. That was the target given to all countries, that you must, by the year 2000, that was not achieved, that was pushed further, but all countries accepted in the World Health Assembly that they will meet this epidemiological target of detecting at least 70% of incident cases and cure at least 85%. Now, no country will be able to, either employ resources or, put together a manpower or drugs or laboratories, etc., without first calculating, what is the task at the hand. So when you say 70%, so epidemiological information is so critically important. Now, of course, this target could not be achieved, but then came in the year 2005, the Millennium Development Goals. And it is the progress, thanks to the epidemiological and pushing countries to continue to achieve targets, that attracted attention of the global policymakers, and the advocacy about the importance of addressing TB helped maintain tuberculosis as one of the indicators for the Millennium Development Goals. I think it was Goal 4, which mentioned HIV, malaria, and other diseases, which included, and they were indicators for TB. And here too, and so here you can see the evolution, that all the components of the Dept strategy have become the first component of the stop TB strategy, the black one. So basically, which says pursue high quality dots. Why? Because this doesn't talk about the Dept strategy, didn't talk about HIV, it did not talk about MDR TB, it did not talk about strengthening health system, because you cannot have only a wonderful TB program sitting on a weak health system. It simply won't function. And for that, you again need epidemiological information on what is the epidemiological burden. And you will learn in epidemiology that there is something called a double burden, because as countries develop, poorer countries have a burden of infectious diseases and a smaller burden of non-infectious diseases or non-communicable diseases like diabetes, heart disease, stroke. And there comes a stage where countries carry a double burden, like in India, for instance, where there are both infectious diseases. And now, how will you allocate resources? That will not be possible unless you apply the epidemiological knowledge to not only just to development of policies, but also to the development of the employment of the funds. Now, so currently we are in what we call the Millennium Development Goals. Of course, the TB goal for the MDGs was achieved in some regions, but could not be achieved, for instance, in Africa. And the targets, again, which have to be epidemiological targets for the Millennium Development Goals, were to basically reduce by 50% the burden of tuberculosis and reduce deaths again by 50%. So without epidemiology and epidemiological information, you cannot really, either develop a policy or measure the progress or set targets and things like that. So similarly, now for the Ntb strategy, which basically builds on the Stop TB strategy, the DOS strategy and the Stop TB strategy has 3 components. And you can see is the learning that the global TB community, which in the DOS strategy only talks about, detect patients and treat them and cure them, and TB problem will go away. That did not happen. Then we, in the Stop TB strategy, we talked about, no, just don't work with the public sector, also engage the private sector. Just don't focus on TB, also strengthen the health systems. Also involve communities, because just the health services doing diagnosing and treatment doesn't help. And the Ntb strategy now goes even beyond that, and it now recognizes the drivers of TB epidemic, which I showed in one of the slides. It is the poverty, it is undernutrition, it is HIV infection, it is diabetes, it is smoking. So no amount of investments in TB alone are going to help us or are going to help eliminate the problem of tuberculosis. You have to, and that's why the need for what we call the intersectoral collaboration. Somehow I cannot show you my next slide, but basically what it shows are the epidemiological targets which are set for the Ntb strategy, and these are to be achieved as a part of the Sustainable Development Goals. So we are expected to end TB, and the definition of Ntb means, making sure that TB doesn't remain a major public health problem. I mean, there is no country in the world where TB has been completely eradicated, whether it's US, whether it is Europe or whatever. Even in the rich countries, TB remains, because there is a definition of what is, so it's not still widely accepted, and it is not a targeted, because we have a very long way to go. But one of the definitions of TB eradication is less than 1 case per million population per year in a country. But for the purpose of the Ntb strategy, we have, our definition is reducing, because this cannot be global, because there is a variation in the countries. For each country is expected by 2030, which is the SDG target date, reduce the incidence of TB by 90% and reduce deaths due to TB by 90%. So again, without these numbers, it is only the epidemiological numbers. It's only when you have these numbers that you can start thinking about what to do, how to, then use these numbers to set up the health services, to address the problem, and then provide resources to run the program. So if you master epidemiology and if you master economics, you can be a master of public health. I think I'll stop there and we'll take some questions you have. Thank you very much.
Thank you, sir.
Sure.
There are already questions. I think you have answered most of the questions that are poured in, but for the sake of clarification, may I ask you a few questions, sir?
Sure.
Sir, in one of your slides was drastic decline in TB reporting after onset of COVID.
Yes.
So with reference to that, the question is there underreporting due to fear of getting misdiagnosed? Or is it risk of catching COVID, which has led to such a drastic underreporting?
I think both. Because I'm saying, as you can imagine, there are multiple reasons why people who are suffering from, because TB doesn't start as TB. TB starts as cough, which is also a symptom of COVID. And as you know, many of during the peak time, especially the second wave, and even now, people are reluctant when they have cough to go to, because especially in the early days, if you have those with symptoms suggestive of COVID were also quarantined, isolated, or whatever. So there was that fear. I think there still continues to be that fear. So both the factors they are talking must have contributed to a reduction in the case detection and notification.
Okay, thank you. So there's one more question. Do you think that the poor primary healthcare infrastructure in rural areas has led to this gap between what is expected and what is reality?
Absolutely. I think so. Only a strong health system can, basically detect. The thing is, increasingly we are finding, because, what happens sometimes is that when governments try and focus attention only on one problem, this often happens at the cost of other problems. And in fact, we have a very classic example of family planning. It was, it was given different names. It was called population control first, then it became family planning, then family welfare, etc.
Yes.
But again, the importance of epidemiology and measurement here. That during the 20 years, during the 10 years, I think, I don't exactly remember the years, but during those 10-year period, all the family planning targets were achieved. The number of whatever condoms distributed, tubectomy is done, vasectomy is done, more than 100% targets were achieved, but at the same time, the population doubled.
Yes.
So you can imagine the impact. So I think you are absolutely right. And one of the why I'm saying is that the entire health system was reduced to a family planning program. And there were a lot of writings on those days and how the population control and family planning program have virtually destroyed the primary healthcare system.
So since this is happening repeatedly, do you think is the lack of manpower and resources both are contributing to the same scenario that we experience over and over again?
Yeah, absolutely. When we say health system or when you say primary health care, well, I see it and we call it, there are 5 M's which can be applied to any or many situations. So these 5 M's are, you have to have enough money for health system function. You have to have enough manpower.
Right.
You must have enough material,
Right.
The drugs or whatever, vaccines or whatever. Then you must have a system of monitoring in place, because whatever gets monitored gets done. If they would have done during the family planning program that the condoms were actually getting to the people, whatever we saw, the doubling of population would not have happened. So monitoring is critical, and measurement. Whatever gets measured gets done. So these are the 5 M's. So when I say a strong primary health system, you have to have enough money, enough manpower, enough monitoring, and all that.
Right. Sir, next 2 questions are linked to this. Do you think lack of data affects policy in India?
Well, in why India? This is true for all settings.
Yes.
Because, and this is in all countries and for all problems. Even, it's only when you know how much your salary is, you can plan, you have a strategy about how you want to spend it. So that's a must. Without data, well, for some reason, if you don't have, there is no way, it's impossible to get data. You have to estimate, you have to have guesstimates, you have to have your hunches. You have to find out some ways, some indirect ways, and you have to assume that this is, let's say, the data. until you get the right kind of data by either epidemiological survey or whatever the right means you have. But you have to begin any policy development. You have to know what is the problem before you and what is the size of the problem before you start addressing it.
Right. There are few more questions. Do you think unregulated private sector is also responsible in some way to this gap between estimated and notified TB?
Absolutely, because as you know, in the Indian setting, and most people, when they fall sick, go to a private doctor. And in fact, this subject is pretty close to my heart because I had the privilege of starting to address the area of private sector engagement in WHO. It was in 1999, 2000 that at the global level, we started collecting information and convincing countries that you cannot hope to do TB control only working through the public sector. And this is especially true in Asia and in Southeast Asia. And India, where the private sector is as big, if not bigger, than the public health sector. And when most people go to the private doctors, you have to work. And I think India, government of India, and the world generally, globally generally, has been huge progress. And I think about a quarter of TB cases are currently notified by the private sector. And much remains to be done, because I think more than half the cases first seek care at the private doctor. So 50, 60, 70% patients should be notified by the private sector. That doesn't happen. And that's a measure. But there are efforts going on. It's not easy, but that's you identify the right problem, and you need to put in a lot of efforts to get the private sector on board. Not just for TB, I think it's true for COVID also. And you have heard both good stories and horror stories. Yes. Of how the private doctors have, or some private institutions have done so well in managing TB, and how some private institutions have exploited this situation to the hilt.
Okay. Sir, do you have suggestion for research topics which will contribute to Ntb strategy?
Well, there can be 1 hour lecture on
okay, yes.
So I want to identify, because depending upon what hat you are wearing, you will have a different interest. Yes. But if you see that, if you look at the Ntb strategy, one of the most important, one of the major components, there are only 3, and one of the third is the intensified research and innovation. And there is no area which cannot be further improved. And you can achieve further improvements only by research. So research has to be an integral part of any policy and strategy if you want to make real progress. I won't list, if you are interested, if you go to the website of the Government of India, the TB program website, I think they have, because there have been many workshops to identify the priority research areas. And just say TB research, and there's a, sea of information. Okay. And you will find, yeah.
Okay. So there is one more question, why data on prevalence of TB from India is not available? You did mention during your lecture that constraint on resources and a cumbersome process of conducting prevalence survey. And one of the surveys which was about to start just before this COVID pandemic could not happen. But is there any other reason why we have this?
No, not to my knowledge. Okay. Because as I said, it's a huge undertaking. It's a very expensive, because, and then because this is done rarely, whenever, it takes a lot to plan. I think the planning for the national prevalence survey in India has been going on for a couple of years. Yes. Because whenever I want to do it, we can use that opportunity to piggyback a whole lot of research. Because to do a national prevalence survey, teams will be going with equipment to diagnose TB cases.
Yes.
Not just by microscopy, but also by gene expert. So there'll be X-rays done, there'll be questionnaires before, after, the whole lot of information. I mean, there's a lot of preparation required. To my knowledge, a lot of work, and there was a decision taken, resources allocated. I think the responsibility was supposed to be with the TB program first, then it was given to, because it's a huge undertaking, the responsibility was given to ICMR, and ICMR is going to conduct that survey. I think they had almost everything ready, but I mean, I don't know, because I'm not I'm not currently working either in the program, or I'm not aware of at what stage the, but definitely it is, in advanced stage. I don't know whether it started with this, no, I don't know whether it's been partly done. I don't know the current status, but when that's done, you'll have, a lot of information about, very precise information about the status of TB epidemic in India.
Yes, that would be really great help to all researchers
Absolutely.
as well as to policymakers. Sir, just one last question.
Yes.
Could you please discuss about the role of Ayush in TB program?
Well, this is a very good question. And again, I happen to be on a working group that the National Tuberculosis Program, or the Ministry of Health, set up with people working on tuberculosis and people working in Ayush. And there is, so we met a few times, and there were people from the Ministry of Ayush, there were people from the TB program, there were experts working in the, the indigenous systems and on TB, and we deliberated, and I won't go into the details, but there is a document now, a guideline on how can the TB program or the Ministry of Health, the TB program and the Ministry of Health collaborate with Ministry of Ayush for the, to achieving TB control targets and goals. And I think this is an area where a lot of innovation is required, a lot of research is required, because, we don't have all the precise information. We don't know what way, for example, the Ayush formulations of drugs, which can help improve immunity, be combined with chemotherapy for TB. I mean, so there are areas of research, but definitely if you just take, there are hundreds of thousands of Ayush practitioners. And there is no reason, and already people with TB are going and seeking care with them.
Yes.
But I don't know that, to my knowledge, they are being actively engaged by the TB programs. So that is something. So there are certain steps which can be taken immediately right now by the TB programs, and similarly from the Ayush practitioners. So I mean, all this is covered, the training that is required for Ayush practitioners, etc., in the document which describes the collaboration between Ayush and the TB programs. So do visit the TB program website and have a look at this document.
Yes. Thank you so much, sir. It was an excellent discussion, I would say. It wasn't a lecture. You actually shared your thoughts and the whole process of changes in the policy and what is required. And it was very enlightening. I'm sure the participants have benefited from today's talk, and we look forward to more interaction sometime in future. Thank you so much.
My pleasure. Thank you, Aarti. Thank you very much. And thank you all.
Thank you, sir.
Bye-bye.
Bye-bye, sir. Tejaswini, I hope you have shared the attendance list for the benefit of students. Okay, thank you.